Hello. Today we're going to talk about Chapter 2, Specialized Imaging Techniques from your pathology book. And this is a short chapter that talks about different types of imaging, ultrasound, CT, MRI, nuclear medicine, and then at the end they talk about fusion imaging, which we will briefly talk about as well. So if you remember your mini rotations in ultrasound, nuclear medicine, and radiation therapy, you may have had encountered ultrasound, which is a type of cross-sectional imaging. It's the first modality of cross-sectional imaging, but it doesn't use ionizing radiation. It's relatively a low-cost type of a procedure. It can differentiate between water-like cysts and for example, lipomas that have fat in them. It can differentiate between the solids, soft tissue, some of the solids in soft tissue, and sometimes tumors and bones. Some of the limitations could be relatively, from the old, could be having a small field of view. Sometimes it's difficult to distinguish small structures that are maybe less than 4 millimeters. And sometimes these procedures take an hour and a half, but it's good that it has vascular imaging. It's real-time imaging, and it's best choice for imaging pediatrics and pregnant women. So we use probes or transducers in ultrasound. A probe has a specialized crystal that produces high-frequency sound waves. Each tissue produces different acoustic properties, and as each sound wave passes through the body, their intensity is reduced and the sound waves bounce back. The probe or the transducer can also act as a receiver and picks up small changes in the signal's pitch and direction. Let's talk about echoes. So echoes are sound waves passing through water and tissue that produce reflections. If a structure is anechoic, it means it's echo-free. For example, water has a good transmission of sound waves. It produces strong reflections which appear dark on the screen. Whenever you have structures that are fluid-filled, like cysts or bladder, they appear dark. Hyperechoic or echogenic. These kind of structures appear light gray or white because of their strong reflections, for example stones, bones, or biopsy needles. Hypoechoic. These are structures that are not quite anechoic, which means they have some echo, but they appear dark gray. For example, GI tract is like that. Isoechoic. These are structures that appear to have the same echogenicity even though the tissues are different. So let's look at some of these ultrasounds. This is an ultrasound of the kidney. It demonstrates a hyperechoic or a white area within the kidney, which shows a renal cell carcinoma. This one is ultrasound guided biopsy, which you might have seen. They do those a lot. And you can see the biopsy needle, which is in this case hypoechoic. How about vascular studies? I'm sure you've seen some patients with diagnosis of DVT that came to ultrasound and had to have a Doppler study. Basically, with these Doppler vascular studies, they can see stenosis, they can see plaques, they can evaluate the blood vessels this way. Major sites that vascular studies done are usually carotids and, as I mentioned, lower extremities. They add color, as you can see it here, so that they can see which ones are arteries. Usually arteries are red and veins are blue on the Doppler ultrasound. This is a renal Doppler ultrasound. Well, let's talk about CT, which you guys are all familiar with. It's a cross-sectional imaging that uses ionizing radiation. It is basically scanning a slice of tissue from multiple angles with a very narrow X-ray beam. We now have 16 and 56 slice scanners, and CTA or vascular imaging is possible and very fast. It's cost effective because it is, even though it is more expensive than X-ray, it's less expensive than MRI. It's very precise. It's good for patients who can't hold still. It's good for your trauma patients. We are able to do reformatting in different planes, which is sagittals and coronals. We're able to do 3D volume rendering, and those are the kind of imaging that radiologists really like to see. A review of a CT, you remember CT number or Hounsfield number, window and leveling. We usually give contrast to patients, either to drink it if we're looking at the GI tract, or IV contrast for the vascular structures. The CT number or Hounsfield number reflects the attenuation of a specific tissue relative to water. As remembered, your CT numbers range from -1000 to +1000, and water is always 0. Different levels, window and level. You could do soft tissue or bone level, window and levels. MRI, magnetic resonance imaging, gives you detailed images in all 3 planes, axial, coronal, and sagittal. There's no ionizing radiation in MRI. Usually doesn't need contrast. Gadolinium is used for some studies. Vascular imaging or MRA is possible in magnetic resonance imaging, and also function MRI is another way of that some facilities use to determine the function of the brain. It does have long scan durations. It is sensitive to motion, and of course, if patient has metal in their body, they can not go in, or if they're claustrophobic, there may be some limitation that way. You do have different sequences in MRI. You have your T1, T2 weighted image. You have proton density, diffusion weighted imaging. Those are all different sequences. Basically, T1 weighted image is mainly for looking at anatomy. Water and structures like CSF appear dark because they have low signal intensity. Fat and gadolinium would appear white on T1 weighted image. On a T2 weighted image, on the other hand, CSF appears bright, which is the image on the right side. Because on a T2 weighted image, CSF has high signal intensity. Fat, bone, muscle, and tendons and blood tend to have a darker gray scale in T2 weighted images. Nuclear medicine, also, again, if you remember your mini rotations, you might have been in nuclear medicine and know that it's the best modality if we want to visualize a physiologic map of a structure, for example, the thyroid or the brain or the lungs. Usually in the nuclear medicine study, patients ingest radiopharmaceuticals or isotopes, or we inject it to them. Those isotopes emit radiation. A gamma camera detects the radiation, and then an image is created from its signals, and then it's sent to a computer monitor for us to look at. It's highly sensitive. It detects things faster than general X-ray. You can have hotspots. You might have heard hotspots, which are areas of increased uptake of the isotopes. Some of the limitations is that it's really not stat. There's some poor anatomical visualizations in nuclear medicine, and it usually has several stages. There's a first stage, and then they have to wait for 4 hours to do the next scanning or the stage. Okay, then we get into PET and SPECT. PET is positron emitting radiopharmaceutical kind of imaging. Patient is injected with radionuclide, producing decays, causing positron emission rather than emitting ionizing radiation. The positron emission interacts with an electron, which causes annihilation and produces 2 gamma rays in 180 degrees opposite of each other. SPECT, or single photon emission computed tomography, uses a collimator that's placed in front of the camera that contains multiple parallel channels. They allow the rays to pass and be detected. It costs less than PET. However, PET has high quality images. The techs receive more dose in PET. And both of these imaging modalities can be used in oncology, neurology, and cardiology. Fusion imaging is a new way of imaging. It's a hybrid equipment that produces two modality images simultaneously. So if you use nuclear medicine and CT together, that's fusion imaging. If you use nuclear medicine and MRI, again, it's fusion imaging, which uses a special software designed to overlap these two modalities. I do have a very short YouTube video that talks about fusion imaging a little bit. I thought that was interesting for you guys to look at. And this concludes our lecture on Chapter 2. Thank you very much.